All right, let's just get straight into it. Today's explainer is all about complex toxidromes. We're completely stripping away the generic textbook filler so we can focus entirely on those exact physiological boundaries and the highly granular decision-making you need when managing critical patients. As a practitioner, you already know that real-world clinical presentations almost never perfectly match the classic textbook descriptions. It's those really subtle variables that end up shifting your entire management pathway and ultimately dictate patient survival.
So we're going to start by confronting what might be the ultimate clinical trap. Picture this. You've got a patient who is just pulled from a burning building. They are completely comatose, but you glance up at the monitor and it shows a 99% oxygen saturation. How? While standard pulse oximeters are only designed to read the percentage of saturated hemoglobin, they literally cannot differentiate carboxyhemoglobin from oxyhemoglobin. Carbon monoxide binds to hemoglobin with roughly 200 times the affinity of oxygen, inducing this massive leftward shift of the oxyhemoglobin dissociation curve. So the monitor is sitting there falsely reassuring you while your patient is actively asphyxiating at the cellular level. That brings us right to Module 1, cellular asphyxiants, specifically looking at carbon monoxide versus cyanide metrics.
Now, both of these toxins cause profound anoxia, but they do it through entirely different mechanisms. As we just saw, carbon monoxide halts tissue oxygen delivery and hides behind a perfectly normal-looking pulse ox. You absolutely need an arterial blood gas with a specific co-oximetry panel to diagnose it. Cyanide, on the other hand, it doesn't play that way. It inhibits cytochrome C oxidase directly in the mitochondrial electron transport chain, totally crippling aerobic oxidative phosphorylation. And here's the kicker. It reveals itself not through a specific immediate blood test, because let's be real, waiting for serum cyanide levels to come back will literally kill your patient, but through high clinical suspicion. We're talking inhalation from burning textiles or carpets, combined with severe unexplained lactic acidosis and unusually bright red venous blood. The absolute key here is knowing your strict interventional thresholds. For carbon monoxide, slapping on a 100% oxygen face mask is just the starting point. You must memorize the hyperbaric oxygen triggers. Pregnancy, and that's because fetal hemoglobin has an even higher affinity for CO. Any signs of CNS or cardiac ischemia, or a carboxyhemoglobin level greater than 25%. For cyanide, the choice architecture forces you to immediately administer hydroxycobalamin to form cyanocobalamin, which the body can then safely excrete.
But what if hydroxycobalamin isn't available? Well, we deploy a pretty brilliant physiological hack. By administering nitrites, we deliberately induce a second toxidrome, methemoglobinemia, to rapidly scavenge and neutralize the deadlier one. The nitrites oxidize ferrous iron to ferric iron, which creates methemoglobin. This methemoglobin has a ridiculously high affinity for cyanide, so it actively pulls it away from the cytochrome oxidase, allowing cellular respiration to restart. It's like fighting fire with a very carefully controlled fire.
Okay, moving right along to Module 2, cholinergic crises and envenomations, let's look at the pathomechanics and interventional sequencing here.
Take organophosphate exposure, which causes massive systemic acetylcholine accumulation. Your patient is going to present with pinpoint pupils, muscle fasciculations, and profuse, life-threatening respiratory secretions. You know, the classic dumbbells mnemonic. The choice architecture here dictates a strictly non-negotiable sequence. Step 1, immediate decontamination to halt absorption. Wash them down. Step 2, push high-dose atropine, a competitive muscarinic antagonist, to reverse that deadly bradycardia and dry up the bronchorea. Only after the airway is completely secured with atropine do you absolutely move to step 3, pralidoxime. This reactivates acetylcholinesterase to reverse the nicotinic neuromuscular paralysis, and it has to be given before enzyme aging becomes permanent. Get this order wrong, and the patient decompensates fast.
Now let's pivot to spider bites, which brilliantly illustrates the stark divergence in envenomation pathomechanisms. A black widow bite injects alpha-latrotoxin, driving a massive calcium influx that forces systemic acetylcholine and GABA release. This results in agonizing muscular rigidity that can actually completely mimic an acute surgical abdomen, though crucially without rebound tenderness. Contrast this directly with the brown recluse, where sphingomyelinase D triggers a localized necrotic cascade. You'll see an erythematous halo that can progress to severe liquefactive necrosis and even disseminated intravascular coagulation.
And here is a huge surgical field trap you absolutely must avoid. We call it the wound rule, which dictates that managing loxoscelism conservatively is paramount. Early surgical excision during the acute inflammatory phase of a brown recluse bite, it almost always leads to drastically worsened tissue defects and delayed healing. You just have to wait. Wait until the necrosis fully demarcates, which takes weeks, before you even consider debridement.
Let's jump into Module 3, Heavy Metal Toxidromes and Chelation Thresholds.
Heavy metal poisonings present with some highly distinct multi-system profiles. Arsenic disrupts pyruvate dehydrogenase, presenting acutely with watery diarrhea, an unmistakable garlic breath, and a severely prolonged QT interval. But let's look equally closely at lead poisoning, or plumbism. Lead directly inhibits ferrochalatase and ALA dehydratase. In these patients, you're going to see microcytic anemia, combined with basophilic stippling, those distinctive lead lines on the gingiva and epitheses, and peripheral neuropathies that classically present as a wrist or foot drop.
Now, you absolutely have to memorize these exact quantitative boundaries for lead extraction. Blood lead levels under 45 micrograms per deciliter, that just requires environmental abatement. Find the source, remove it. Levels from 45 to 69, assuming there's no encephalopathy, mandate oral succimer. But a level of 70 or higher, or any presentation with acute lead encephalopathy, is a full-blown neurological emergency requiring a strict multi-drug sequence. You must administer intramuscular dimarcable first, followed strictly by intravenous calcium EDTA. If you do this out of order, you are quite literally shifting toxins directly into the central nervous system.
Take a quick look at this arterial blood gas. We see a patient who is technically on the alkalemic side with a pH of 7.43, but with a profoundly low PCO2 of just 22. This points directly to our next big metabolic trap, salicylate toxicity.
The reason this is tricky is because salicylates force you to manage a highly dynamic, shifting acid-base target. Large doses initially stimulate the central respiratory centers, right? That causes hyperventilation and a primary respiratory alkalosis. However, this is rapidly followed by a severe, delayed anion gap metabolic acidosis. Why? Because the drug decouples the electron transport chain, forcing the body into anaerobic metabolism and triggering massive lactate production. The management here requires really aggressive systemic alkalinization with sodium bicarbonate.
Finally, let's wrap up with Module 4, Clinical Reconciliation and Disruptive Field Traps.
These are the disruptive field traps that will catch you completely off guard if you aren't paying attention. As we just discussed, administering calcium EDTA before dimercaprol in severe lead poisoning fatally drives lead straight into the brain. Or how about administering flumazenil to a patient with chronic benzodiazepine dependence? You're going to strip the receptors and trigger intractable, deadly withdrawal seizures. The historic treatment of using calcium gluconate for black widow bites? It's been proven completely ineffective. And in severe COPD presenting with right heart failure, giving diuretics without prioritizing home oxygen completely ignores the hypoxic vasoconstriction that's driving the failure in the first place.
Here's another classic sequencing error seen beautifully in this presentation of anaphylactic urticaria. Anaphylaxis is an IgE-mediated hypersensitivity causing profound multisystem vasodilation and bronchospasm. Any delay, and I mean any delay, in administering intramuscular epinephrine because you wanted to give H1, H2 antihistamines or systemic glucocorticoids first directly increases the risk of cardiovascular collapse and death. Epinephrine is literally the absolute only agent that reverses the underlying vascular mechanics immediately. Don't wait.
Moving over to electrolyte boundaries, let's talk about the ultimate physiological speed limit, the sodium correction rate. In acute severe hyponatremia, the brain adapts by shedding its intracellular osmoles. So if you go in and aggressively correct the serum sodium faster than 6 to 12 milliequivalents per day, that newly hypertonic extracellular fluid exerts a massive osmotic pressure. This causes rapid, devastating water efflux from the neurons, resulting in central pontine myelinolysis. You're looking at irreversible destruction of the pons that permanently locks the patient in.
So, as we wrap up these incredibly dense physiological pathways and interventional sequences, ask yourself this. When you are standing there at the bedside and the data is completely contradictory, are you truly prepared to spot the subtle variants, the falsely normal pulse ox, the early respiratory alkalosis, the rigid abdomen without the rebound? Because recognizing the variable that alters everything before the patient decompensates, well, that's the whole game. Master these boundaries, and you master the crisis.